Father Innocent, you can go ahead.
Okay. So let us start with the word of prayer. We take a moment of silence and recollection in front of our Almighty and merciful God. Let us pray. Almighty, merciful, and compassionate God, you are our refuge and strength in time of need. Be present to people who need your loving touch because of COVID-19. Take away our fear, anxiety, and feeling of isolation. Help us to care for each other, especially for those who have recovered from COVID-19 and those whose relatives are sick. We cast all our anxieties upon you because you care for us. Bless this initiative of the Interfaith Initiative and bless our session tonight. We make our prayer through you who lives and reigns forever and ever. Amen. So welcome, dear distinguished panelists, to this second session on reflection on COVID-19. I am Father Innocent Maganya, lecturer at Tangaza University College and the director of the Institute for Inter-Religious Dialogue and Islamic Studies. Welcome. Mine is to give you a brief overview of this initiative between Tangaza University College, Uma University, and Harmony Institute. Dear respected Vice Chancellors, DVCs, scholars, religious leaders, participants, representatives from different institutions, universities and organizations, governments, and development partners, welcome to the second international series of webinar by the Interfaith and Inter-University Africa Forum. This initiative aim is to bring together interfaith groups and faith-based academic institutions from all over Africa in order to create awareness, deepen understanding of the critical issues affecting Africa from time to time. Both our first and second international webinar are dedicated to COVID-19. We are inspired to establish a continent-wide network to drive change by exchange and sharing of knowledge and experiences. The Interfaith and Inter-University Africa Forum is proud to network with African governments, Africa Union, United Nations organizations, development partners, with the objective of contributing and shielding of the vulnerable groups in the continent from this pandemic and other challenges. This unique initiative is inspired by religious virtues, values, and teachings that has potential to reduce death, suffering, psychological problems, and avoid economic regression, and eventually control the pandemic and other problems in Africa. The Interfaith Initiative will work to assure the realization of sustainable health system, peace and development agenda through collaborative partnership and faith cooperation in Africa to achieve social transformation and improved quality of life. The initiative has inbuilt strategies as envisioned in Africa Union Agenda of 2063 and UN Sustainable Development Goals, whose broad framework is Leave No One Behind. The objective of the Interfaith and Inter-University Africa Forum is to organize forums that analyze the interaction between humanity, systems, and nature for enhanced sustainability of African societies in the future. To advance cultural knowledge and dialogue through collaborative partnerships and experience sharing. To apply and undertake research to solve real-world sustainability problems in Africa societies. To promote solution-oriented projects on inter-religious dialogue and community development to drive social transformation in Africa. To promote collaborative partnerships between academia and religious organizations. We look forward to be joined by many collaborators and partners in support of Africa-wide movement for sustainability of African societies in future. We would like to thank in a special way all our panelists tonight. You are all welcome. It is my pleasure now to invite Professor Macharia Munene, who is our moderator, to proceed with the program. Professor Macharia is a professor of history and international relations at the United States International University, Nairobi. He obtained his doctorate in diplomatic history in 1985 from Oyo University, Athens. Dr. Munene has served as collaborating international faculty, Universitat Jom, Castellon, and professional affiliate of the National Defense College, Karen, Nairobi. He also taught at the University of Nairobi, where he was chairman of the department, Kenyatta University, Moi University. The Oyo State University, Kentucky State University, and Oyo University. Dr. Munene has also served as an external examiner at the University of Nairobi, Kenyatta, Masinde, and Ergeton universities. He is recognized as the public intellectual and resource person. He has received the United Nations recognition as an expert on decolonization. He is also rated among the top 10 CCTV commentators in the world, and appears in Kenyan and global media and public forums as an observer, analyst, and columnist. Dr. Munene also serves as an advisor to the Harmony Institute in Nairobi, Kenya. He is the one who is going to moderate our session tonight. So, Professor Munene, thank you and for accepting to moderate this session. You are welcome.
Thank you very much for the Innocent. It's my pleasure to moderate this session, and today a distinguished panel of eminent personnel. I'm not going to them, except Dr. Oscar Gedua, Kenya Psychological Association. So the people who look after some people who have problems, he's involved in that. We have Ambassador Mosi Issue. We missed you, Ambassador, last time. And Paul for the what happened. We have Sheikh Ibrahim Lafome, associated with SUPKEM. He is the legal advisor in Kenya and a prominent scholar in Islamic studies. We do have Dr. Francis Kuria, Director Public Health in Kenya, and very involved in all information about where we are and how far we are, and whether we are recovering from the coronavirus. He is very well knowledgeable in that matter, and we are pleased to have him with us. We have Professor Hodan Issa, University of at Buffalo in Somalia, School of Management. Professor, welcome to Nairobi through the web. And we are glad to have you. And we have all the way from Italy, Brother Dr. Dana Kamboni missionaries. He has served in many places. He was telling me that he lived in Uganda for a long time and he has visited Kenya many times. And now he's visiting through the web. Thank you very much, Brother Doctor, for being with us. And we have Sheikh Rashid Omar, former Deputy Chief Kathy in Kenya and Harmony. So thank you all for agreeing to come. And we have some limited time. So each panelist will be given roughly 7 minutes to give their views about this topic as best as he or she can. And then we move on. At the end, we hope we shall have time to respond to some questions that may come from the audience. And sometimes there are very good questions that come from the audience. And then each of you will get time to respond to whatever may have been directed at you or general comments. So we shall start with His Excellency, Ambassador Hailu. Ambassador.
Thank you, Professor.
You have 8 minutes.
Thank you, Professor. Dear friends, colleagues, brothers and sisters, I present you greetings of peace and blessings on behalf of 262 member organizations of United Religions Initiative from 232 Africa countries. I have a privilege of serving as a regional director for United Religion Initiative Africa and representing at the African Union and the United Nations. United Religion Initiative is a grassroots interfaith organization which is working to promote enduring daily interfaith cooperation, to end religiously motivated violence, and to promote a culture of peace, justice, and healing for the earth and all living beings. And we are working very closely within the African Union. We have an MOU, and we have also consultative status with the United Nations Economic and Social Council. Before I share with you my remark on this very important topic, I kindly ask you to join me to observe a moment of silence to remember all those who lost their precious life due to COVID-19 pandemic. Can we observe a moment of silence? Thank you. May their soul rest in peace. Allah nafs yarham. At the outset, I want to thank the organizers of this very timely and important webinar on the issue of COVID-19. I would like also, we'll share with you what the AU Interfaith Dialogue Forum, which is established at the African Union level, managed to do something around this issue, and also we'll share about how we can bring the moral, spiritual dimension to this work.
Your Excellency, are you still there? Maybe as we wait for His Excellency to rejoin, may I call on Brother Daniel? Please, Brother Daniel.
Thank you, Professor. Yeah, I will step in while we wait for the technology. We hope it will not fail us. Thank you for the invitation that was extended to me. I must say that I was a bit surprised at the outset, because looking at the fact that the panel is contextualized to the problem of COVID in Africa, I said, but yes, I worked 30 years in Africa, first as a physician, then as a public health specialist, but I left Africa, East Africa, I was in Uganda, 10 years ago. And since then, I've been working in a nursing home for old missionaries I'm a Comboni missionary myself, and for all missionaries that come back from Africa and Latin America, and they spend their last period of life being nurse because they have lost their own autonomy. So the only thing that I could offer is the experience of a person that was managing a healthcare institution for old people. Old people are the most severely hit by those that develop the most severe form of COVID-19, because most of the deaths we had in Italy were among old people with multiple diseases and so on, and had to cope with the presence of the epidemic in its nursing home. So that is my experience. So I offer to share my experience and the lessons that I learned. Few of the lessons. There are many we are still learning now as things go by, because by no means the COVID epidemic is over. I mean, the first big wave in Italy is over, but we had a lull of quiet life, but apparently it's coming back. And as winter is approaching, we are at the beginning of autumn, the cold weather will come, we don't know what will happen. So we have to brace ourselves for a possible second wave. We hope it will not come. But let me go through the experience I had, because the first time I heard about COVID was from the news that it was a problem in China. And that was at the beginning of January, end of December, beginning of January. It was a faraway problem. Then on the 21st of February, we heard there was a first case reported in my region in Italy, not far away from here. I live in Milan now, northern Italy. Not far away, the first reported case of COVID-19 as a disease, confirmed as in its origin by SARS novel virus, that is the name of the virus. But I said, well, it's one case. 2 days later, I heard that there was, that was the 23rd of February, that there was a cluster of several people affected 50 kilometers from here. And the following day, I locked the nursing home. The decision that I took, knowing, being a public health specialist, I said, well, let's lock in so that we stop the disease at our doors. Hopefully, only few people were admitted, no relatives, unfortunately, no relatives, no visitors, only the health staff. We were going out, we reduced our exits in order to avoid bringing the disease. And we thought that in that way, we had protected ourselves. It was already too late. So this is the first lesson that we learn. When you hear that the disease is somewhere nearby, it's already in your house. It's already, or probably already indoor. And that became true for me only 2 weeks later, when, having expected to have been able to curb the entrance of disease, the superior of my community, not a host, not a guest of the house, but a colleague of mine, those who was managing the people that had lost their autonomy, started developing fever. At that time, we did not have ways and means to confirm the origin of there were no swabs, There was no PCR. I mean, there were 2 hospitals in the country that were doing the diagnosis, but it was very difficult to get a confirmation at that time. Now, I think we are having about 90,000 tests done every day, and they're still not enough. They're still not enough. But at that time, there was no way of understanding whether that was a common cold, was a bronchitis, or it was a rhinovirus, it was a coronavirus. We didn't know. But we isolated that person. We put him in a room. I was the only one with the nurses entering to visit him. And we thought that at least in that way, we would have contained the disease and limited it to him. It's not true. Yeah. After 10 days, other 2 people started developing fever. The following days, other 2. At the end of the entire venture, 9 people developed COVID, 5 died, 4 recovered. The index case, the person that through whom I became aware that the problem was inside Father Joseph, stayed 1 week with us because he was not very sick. It looked like a common cold. It looked like a common, I would say, not even that, fever, just fever. And he was okay. 7 days, and then he starts developing some difficulties in breathing. And most of the people who died because of respiratory distress, okay? And at that time, we admitted him to a hospital. And the second thing that I discovered is that we could not visit him. He was in the hospital and was in the hospital alone. I was the last to see him living on the ambulance. Nobody could visit him. For 2 days, I was able to talk to him through the mobile phone. After 2 days, I got no more replies. Nobody was calling me from the hospital because at that time, the hospital was already overwhelmed by the number of people. We live 1 kilometer from the major hospital in Milan, 2,500 beds. And many of the hospital departments had been converted into COVID departments. So from here, we could hear the wailing of the sirens and the helicopter that was bringing people in from far away to be assisted in the large intensive care unit of the hospital, but it was already overwhelmed. So they were not able to contact the relatives. So by the time a doctor called me, it was already too late because Father had died. And that was 12 days after the beginning of the disease. So people, your dear ones, once they fall sick, are alone. And that is an experience that I think most people who have gone through any kind of disease really would not wish to live. But no one would wish to live that experience for his dear ones, even if as a relative of those who are sick. It's a really distressing thing. So when we were back at the fact that despite the fact that we acted very fast, we did what was right, it was already too late. Gives us a clear message. We were not ready. We knew, Dr. Gitua will confirm, that as a public health specialist, we knew that the pandemic would be somewhere on the line for some times. We had already two scares in the past years with the Meds, with the MERS and with the what do you call it, the avian. But luckily enough, it did not turn into a pandemic, but the public health specialists knew that a pandemic sooner or later would come. A pandemic like the last very large pandemic of the Spanish flu 1 century ago. The Spanish flu crossed the entire world 100 years ago. It killed about 50 million people, 50 to 100 million people, and it lasted 2 years. It had 3 waves. This is why we are saying we are not very comfortable with what we are living through, because in Italy, the first wave has passed. The country had a teething moment, and I speak as a citizen now. Our government had a moment of uncertainty because there was we didn't know. Nobody really had to confront, no politician, no decision maker had to confront a major epidemic in recent years in our country. This is the first that has really that has really caused big trouble. So they were very aware that the measures of containment were not very welcome by people. Having to tell people that they have to stay indoors, that they cannot go to work, that they have to wear masks, they have to keep washing their hands and washing again. They have to renounce to the expression of their feelings, because I mean, well, Italians are a bit physical in their expressions. They embrace, they kiss, they shake hands, a bit like Africans, if I may say. But we had to abandon all that, because the disease can spread through physical contact if one has passed his own hands on his face, on his nose, on his mouth, and then it can. Telling people that they cannot do that is not easy. Telling people they cannot gather to rest in restaurants, it's very difficult. So this is the second thing that we learned, that measures need to be very, very, very hard. They are effective because the wave eventually tapered. And we have seen it, the disease has decreased, the contagion, the spreading of the disease has decreased. For 2 months, we have been very comfortable with that. And because we have relaxed, now it's coming back. Because numbers are now re-increasing. Will there be a second wave? We don't know. But we know that the transmission rate is there, ranging above 1.2. The epidemic is spreading once again. Of course, we are no longer the second worst hit country. We are now ranking the 20th, but there's no consolation because you can easily change your own level of rating. These are the lessons we learned. The measures are effective. Masks, limitation of social distancing, avoid gatherings and so on. They are very unwelcome, but they are effective. But everybody needs to adhere to that. I think my time is through, Professor. Is it?
Thank you very much, brother. And we pray that Italy will not go back to being number 2 in any way. Now, may I call upon Professor Hodan Isse? Tell us something, 8 minutes. Unmute yourself.
Some claim that if there is one area that vividly sums up Africa's development challenge, it's the field of healthcare. Some of the challenges are underfunding, lack of access to basic healthcare, which contributes to millions of deaths, particularly in the Horn of Africa. World Health Organization claimed that Africa carries 25% of the world's disease burden, but its share of global health expenditure is less than 1%. Luckily and comparatively speaking, countries in the Horn of Africa are undoubtedly ahead of the curve regarding their approach to COVID-19 containment. Countries in the Horn of Africa are exponentially less cases than countries in the West that continue to struggle despite the advantage of well-funded and well-developed healthcare systems. In my humble opinion, the full impact and devastation of COVID-19 in the Horn cannot be assessed accurately due to the following reasons. In the Horn, particularly in general in Africa, one of them is the stigma. People may fear reporting becoming positive due to potential backlash, isolation, and being labeled as sinners. Furthermore, the belief that this virus is a divine punishment has prevented others to go to the hospitals or to even report the virus, The second one is the misinformation, dissemination of untrue and harmful information regarding how people contract the virus, how it spreads, and the cure. Fourth, lack of widespread and easily accessible testing. That was also a problem. It still is a problem, and the lack of testing leads to underreporting and skewed a perception of how persuasive this virus really is in the Horn, in Africa, or in Somalia. Lack of institutional capacity and lack of effective measures, as Dr. Daniel said, is also compounding this problem. In the case of the Horn, especially Kenya, Somalia, some of the Ethiopia, no one can tell the status of COVID-19 in villages and in the rural area. In the case of Somalia, particularly, Somalia continues to suffer from 3 decades of civil war. The following socioeconomic and insecurity conditions were exacerbated by this pandemic called COVID-19. Number 1 is unequipped and ineffective governance, non-existent or obsolete or poor funded healthcare system, lack of delivery of basic social services, lack of preparedness, lack of revenue that's too low to provide healthcare resources to combat the spread, conflict and polarization that's based on region, religion, and clan. Thirdly, recurring natural disasters like droughts, flooding, locust, famine, among others. And of course, potent insurgency. Al-Shabaab spread misinformation and prevented help from being delivered to those vulnerable, poor communities that were located in the area that's controlled by Al-Shabaab. The disproportionate effect of the virus on vulnerable communities such as IDPs, other migrants, especially in the Horn, the migrant routes taken by migrants and other groups and displacement settings by nature are more exposed to conditions where COVID-19 spreads. In the case of Somalia, people are actually shamed publicly for wearing masks and being called COVID-19, suggesting they have the virus. And that has dissuaded many to take these measures, even though the government in many different regions, of course, you know, the Somalia is now divided in different regions. Each one has taken different measures. There's no universal system of healthcare that applies to all. Despite these issues, I want to reinforce that compared to the rest of the world, Horn of Africa have made COVID-19 a national, regional, and local priority. They have implemented rules and enforced them. For example, workplace social distancing, even though in Somalia lately, especially in the beginning of June, where they were celebrated the different celebrations, Independence Day, so forth and so forth, you could notice that there was no social distancing. People were not wearing COVID-19, the masks and all these things, but there was some measures such as school disclosures. But these measures, even though we're not still out of the woods with the virus, have been a little bit relieved and relaxed in case of Kenya, Somalia, even in Ethiopia, which is worrisome, to be very frank, because we do not know whether we are still getting more or less, and so on and so forth. The lack of data also compounds the problem, especially in Africa. I think my time is up, and I would like to hand it back to the chair. Thank you.
Thank you very much, Professor. Keep up the good spirit. May I now call on Dr. Francis Kuria to tell us what he knows. Dr. Kuria, 8 minutes.
Thank you very much, Professor. Thank you very much, the rest of the panelists. Unfortunately, my internet is a bit unstable, so if you don't get me at some point, kindly let me know. I represent the ministry as the head of the Directorate of Public Health at the Ministry of Health, Kenya. This is a docket that I've held since March. And you may have heard from my short intro that my main training is as a surgeon. And this docket of public health and dealing with a pandemic like COVID-19, as Dr. Daniel says, of course, took all of us by surprise. Coronavirus being a new virus, of course, it's very little known about it, poses also another great challenge to all those who manage it. Now, as a ministry, of course, we got our first case on 13th March. And all we had heard about is the pandemic spreading through China, Wuhan, China, through Europe, and finally into Kenya. And of course, it came through air from international arrivals. And since we got our first case, I'm sure you've been watching our daily presses, and we have today in Kenya about 36,300 cases out of a total of 502,000, those 3 tests conducted since the onset of this pandemic. And this far, the government has instituted several containment measures aimed at curbing the transmission of the virus, which is mainly the spread, as we have all heard from the other panelists, through droplets emitted from the mouth and nose of an infected person, either directed to another person or through those droplets landing on the surface of the second person who picks it up and then applies this either onto the face or the nostrils, and the infection then gets into the individual. The government has said placed a number of measures, and today we are discussing the topic of stigma. And most of these measures, of course, some of them are quite drastic. For example, restriction of movements between, into and out of cities like Nairobi, Mombasa, Kwale, Kilifi, and Mandera. We had closure of entertainment places that offer lots of relief to most of our Kenyans in terms of stress management and stuff. We closed our places of worship, and I'm glad that we are here joined with the Interfaith Council. This had its own impact. We imposed dusk to dawn curfews throughout the country. We suspended international travel. Those who wanted to travel could not travel. People had relatives out there. People had relatives who wanted to move out. And all these had their own issues. We had then lastly closure of schools, and the students then had students have to stay at home since March, and they are still there. And of course, worst of all was the imposition of quarantine on all those who are arriving from international travel and those who may have gotten into contact with the positive cases. Now, these measures have not been without, of course, a measure of an equal measure or a fair measure of both psychological and social and economic trauma. And one of the biggest challenges in the management of COVID-19, as we sit at the directorate, is the word stigma. And I know that the main topic today is stigma, but that has been the main culprit, the main stumbling block in the management of this pandemic. And I am glad that we are here to discuss this topic. And one then would ask what stigma is. But stigma is a mark of disgrace. Is associated with a particular circumstance that I have COVID-19, I'm disgraced by those who are near me. Sometimes you are disgraced even by family. Nobody wants to get close to you. Even those you knew, including religious leaders, don't want you to go to the places of worship because you are labeled COVID. As a Christian, of course, when from a Christian perspective, of course, you have to associate stigma with what happened historically, that it represents the marks of Christ, the marks on Christ's body coming from his crucifixion, meaning that stigma then has long-term effects in our body, just like the marks that we have on Jesus Christ himself. So in the same way that we have this COVID-19 infection, it is associated, of course, with certain degrees of disgrace in society, and it creates a sense of fear amongst people. The rest of society do not want to associate with the infected person, even after he has recovered. And this leaves the affected person with a sense of confusion sometimes, alienation and loneliness and despair. And to this extent, those that may turn positive do not even want to be known by their close friends and relatives of their status, lest they also alienate them with nicknames such as, in Kiswahili, mtu wa corona, or a corona person. This is a nickname that is, I once witnessed an evacuation of a COVID positive patient, And as the ambulance stopped and the men clad in white stopped and you could hear men around you, Watu wa Corona. It's a very bad title that is given by the public to those who are affected. And of course, this will progress on and depression that starts setting in. And this may even progress to especially to the vulnerable groups, into suicidal tendencies. And this is always the first response in almost all of us. Of course, as the pandemic grows, we are all running to respond to this in a better way. You may all well be aware of what we saw from social media when the first cases were reported in China, with very bad reports that people are being put in pits, people are being murdered, people are being in lockdowns. We never believed it. So what cropped in then after that was fear. I do not want to be labeled COVID-19. The rest I face what I'm seeing happening in China. I do not know whether that was true or not, what we saw on social media. Of course, in this country, we didn't do that. But that fear has always been there. Nobody wants to be labeled COVID positive. Nobody wants to associate with someone who has COVID. And to that extent, then as a ministry, we have been fighting very hard to fight this topic of stigma, which is the main topic of today. And from the very beginning, when we started witnessing stigma setting in and fear and despair among the quarantinees, then we set up a call center 719 that could respond to most of your psychosocial needs on a 24-hour basis, using a pool of trained psychologists and counselors. And then, of course, nationally, initially we were just handling a few cases, but the cases have since now escalated to the rest of the country. And we have then had other partners partnering with the Ministry of Health. For example, the Red Cross has also been running a call center 111179, and it's good to inform the public here that that call center is still running, it's 24 hours, and it is there to offer personal and group psychotherapy to Kenyans who may feel affected or infected with the virus. The ministry has also worked closely with other partners, including the Kenya Red Cross, the AMREF, in training a huge lot of and sensitizing lots of people through community health workers on the effects of COVID-19 and how to cope with stress and the psychosocial stresses associated with COVID-19. We have also tried and administered to try and encourage those who have recovered from COVID-19 to come out in public and talk to the rest of us that COVID is a flu, that you can recover. It does not always, it's not a death sentence. And I must encourage, you must congratulate two of our very good champions that came out very strongly, including a very strong personality in the government. And I'm sure he was on TV, many may have watched him, and I may want to mention his name here, Ambassador Macharia, who came out openly on TV to declare his status and has recovered. Would encourage many more Kenyans to come out and tell Kenyans, this is not a death sentence, that COVID is an illness like any other and they can recover. We are continuing to do a lot of sensitizations in community using our community health volunteers, of course, with the help of our partners, Red Cross and AMREF, as we said. We have also set up what we call the psychological support first aid centers across the country. And again, we are doing this training of social awareness community health workers to provide this first aid to those who may need it most. Then all throughout the county, we have set up a county mental health teams so that they can offer psychological support to those sufferers throughout the counties. We are also increasing our capacity by hiring more psychosocial workers, psychiatrists and mental health workers to help cope with those who are affected by COVID-19. And we must congratulate one of our partners here, the World Bank, that has also helped us to hire a number of psychosocial support groups, psychologists to work in the National Psychosocial Support Group. Of course, as a parting shot, and one of the challenges that has been raised here by Dr. Holden here, is that we've seen that there's a lot of media publicity right now about the curve being flattened. And I would warn, like Dr. Daniel has also said here, the curve is not yet flattened. It's a big question of reporting, and we need to be very cautious, even as we go out as religious leaders, as media, of what we tell Kenyans that the curve is flattening. The curve has not yet flattened. We may have challenges in reporting, challenges in testing, but I think the curve is not yet flattened. Two, you've heard Dr. Daniel here talk about resurgence of the infection, second and third wave. In this country, Kenya, I don't think you're even through with the first wave. So you may not start talking about the second and third waves. We are still dealing with the first wave. And Kenyans need to be enlightened here that we are not yet through with the first phase. and they cannot let their guns down. Let's continue our containment measures as much as we can. Of course, we are concerned about what we are seeing currently. People are now starting to go back to their normal. They are now hugging, shaking hands, and the hand washing that was there when we started the campaign is no longer there. We need, as religious leaders meeting here, to strengthen our resolve to tell Kenyans, tell the rest of the world that we need to avoid this infection as much as we can and avoid this second, third, and fourth waves that are along the way. I will end there, Professor, and thank you for that moment.
Thank you very much, Dr. Tari. I'm sure people have heard, don't let down the guard. We need everybody healthy. Now, may I call on Sheikh Rashid Omar, 8 minutes. Sheikh, unmute yourself.
Thank you very much, Professor. I thank Allah Almighty who has allowed us to have this congregation. In addition, I welcome all who are with us here. May God bless us all and they put us into his mercy. The way the doctor before me has said that COVID-19, the topic we are dealing on COVID-19 is managing social stigma and denials. And the way his definition, I'm near to his definition, stigma is said to be disqualification from full social acceptance. And when we come to denial, it is a relative issue. It can be exclusion, but in this case, it's people refusing to accept the existence of actually the disease. I will have some small introduction on COVID-19. Then from there, I will go to mitigating factors, of which many of them has been mentioned by the doctor in our case here in Kenya. First and foremost, in theorizing COVID-19 as a natural phenomenon, man throughout his ages faced various difficulties and hardships and disasters due to negative occurrences. This situation is envisaged in our holy books, the Quran and the Bible. About 14 chapters of the Quran did touch on this issue of being all over the room, man having these difficulties. If we go into the Bible, the Old Testaments like Psalms, Proverbs, and Nahum states the same. And the New Testament, 1 Corinthians, and Matthew also mentions the same. And all these incidents which were happening to mankind carried with them complex instabilities and destabilization of systems at diverse intensity, time limit, and forms. Historical traces reveals facts of calamities being a near synonymity to man's existence on earth. Among these histories are the periodical epidemics and the pandemics, mainly in certain geographical range. Irrespective of the impairing repercussions that these diseases and the other calamities may have, man did apply also various mitigative skills and the creation of coping strategies to bridge the problems and the conditions they have. Today, we are here with COVID-19, a serious disease, a new disaster, and that imaged itself into a unique and unprecedented entity for perplexing the whole entire world. In relation to degree of spread, intensive media coverage, and also universal economic depression, including losses of many jobs and deaths. Africa, being one of the larger continents of the world, has its share of the COVID-19. However, I feel, in my view, there is a light in the tunnel and good hopes for Africa also, though the doctor before me said that we are not out of the wood. I agree with him, we are not out of the wood. However, the African Center for Disease Control's report indicates that the spread rate has been in decline by 10% in the past 4 weeks in relation to the number of weekly reported cases. That is a good hope, but we should not rely on it because the waves are being said coming up, and I hope God will protect us against these waves. To deep myself into the subject matter, sociologists and psychologists did inform that all negative eventualities, including pandemics destabilizes the social fabrics of society, which is very dangerous societies. That's what happens then. They engineer antisocial consequences, including but not limited to stigma and denialism. Thus, this situation quirks the positive relational factors in the communities or world communities of the society. Therefore, I will just touch one by one and propose the following mitigative measures for Africa to handle this matter. The first thing is that constant prayers. Africans are religious communities. Therefore, it is important that we turn to God and constantly pray and face Him with dedication that these pandemics may be removed from us by Him, because He is the one to do. Other measures are just a subsidiary, according to me, or to the religious leaders. Then the issue of stigma is serious, and it is not limited to only these pandemics. Therefore, it is a general issue. What is required is therefore that we have to use the existing international and regional and national legal instruments against stigma and denials. We have to formulate a specific social policy addressing the concept of stigma and denials. Religious leaders and institutions are to whip their subjects against all sorts of stigma and denials through scriptural teachings and other religious literatures. The notion of stigma and denials happens to be located at individual, familial, and also societal level. Hence, there is the need for holistic radical reframing to mental perspectives of the African communities. Instill social empathy to victims of stigma and denial through reclaiming the African heritage of mercifulness, relief from sufferings, relentless advice, and the collective responsibilities toward the plight of those people who are the victim, the weak, and the destitute. To enhance public education campaign against the stigma and denials at all levels of social institutions. To inculcate paradigm shift from shock cognition. We are now in shock. Most of the people are yet not out of the hook of the shock. Therefore, there must be paradigm shift from shock cognition to normative cognition to the problem. Dissemination of circuiting information through extensive media coverage and other transmission techniques. Involvement of societal opinion leaders and other influencers in the fight against the stigma. Formulate standard interventions and strategies to collective implementation throughout the continent. Establishment of humble psychological care units for the victims. Activating person-to-person social cognition and the factor alertness to the threat of stigma and denials. Encourage interpersonal interactions and functionalism to boost the positive African culture, cultural values, those mitigating stigma and denials. Combat the emerging threat of stigma discourses. The way the doctor has already mentioned, we have to combat the emerging threat of stigma discourses and any other devaluing terminologies. Fight misinformation and rumors, those encouraging stigma through building trust within the communities. On the perspectives of denial, it is required that they must be offering extensive professional guidance and counseling to patients in denial to accept the realism of the situation we are in. Those in denials be encouraged against ignoring advice of loved ones and the professionals equally. Unless denials are handled at early stage, it may develop into complex conditions of serious denials requiring professional attentions and academic attention. We have to sensitize communities and individuals to the negativity arising out of in denials, including consequential health problems, especially those with mental health struggle. Counseling service also be extended to relatives of victims for the situation because it may prolong to them by refusing to deal with consequences of ill health and deaths. Talking widely about COVID-19 is an element of problem solving and managing techniques to our problem. To conclude, in my mind, unless stigma and denials are taken care of promptly and meticulously, they may degenerate into a total social exclusion. I pin to this position. Thank you very much, Professor.
Thank you very much, Sheikh, for your advice and suggestions also for what to do. They are very good. And with that, I'll now call on Oscar Idua, who is a psychologist and will know what to do with your proposals. Oscar, you have 8 minutes.
Thank you. Thank you so much, Professor Munene, and also thank you so much to the other esteemed panelists. It has really been enriching so far, and I think that I am so honored to be in the company of people who are actually very well accomplished, and also, of course, I can see here people like Dr. Kuria, who I know he said that he was taken into the deep end, especially when he was appointed into his position. Dr. Ari, we are with you, and I really appreciate the work that you've been doing at the ministry. It's really great. This is a very good initiative, and it will actually help us to advance the conversation about COVID-19 on our continent, and especially in the Horn region. And for me, I'll limit my experience to Kenya, and hopefully we can be able to see if we can actually talk about it a bit further. As a mental health practitioner, specifically a forensic psychologist, I'm honored to have been part, and I'm still part of the National Mental Health Task Force, which was appointed by Cabinet last year in December. And we have a lot of good recommendations we made based on our picture of mental health in this country. And of course, I can actually post that in our chat section so that our members can be able to access that to read for themselves. Of course, COVID-19 has been covered from many angles, but today I'm among religious practitioners and scholars, and I must say that I'm really, really impressed. And especially, I always tell people who I teach at any one point that if they spend time with religious scholars, they would actually learn more beyond the theory, and they would actually understand how application of scientific concepts actually can be synergized with what actually happens in the spiritual realm, especially, and also the cultural realm. So I'm really honored to be in this space. I'm not a religious practitioner myself, but I stand guided. If I go off a bit, please feel free to guide me back. I'm a psychologist, so I'll stay in that lane. However, I do not think that psychology is necessarily very different from any other cultural or spiritual expression, because you cannot separate a human being from those kind of things. And especially in Kenya, If you talk about our socioeconomic experiences, our cultures, our spirituality, our static and dynamic risk factors for mental health issues, and also our historic trauma, which is a topic that Professor Munene knows I'm very, very passionate about. As a people, we then, by the time COVID was coming, we already had our own pandemic going on, which is a mental health pandemic. So I want to talk about that mental health expression, especially compounded by COVID-19, as opposed to what COVID-19 has come to do. We already have been having this. And so this is what I think I want to take the time to express about. Also, remembering that our mental health system has not been really that stable, especially to support our patients and people who might require the care. This is another thing that we have to understand, that our systems have not been really strong. So even as we talk about mental health, let us remember that when we tell people to seek help, where are we telling them to go to? As a member of the task force, we realize there's a lot of gaps, and I think we have a roadmap now to actually address that through the mental health policy that we do have in the country. So these factors that I've talked about are not limited only to the COVID-19 pandemic. As I've said, we have many other challenges in Kenya on the economic, social, as well as political fronts, which have also been compounded by COVID-19. So maybe this singular pandemic might be what will make us wake up and start thinking about what we do about our system to improve it for our people. And to actually illustrate this, just as recently as last week, His Excellency the President was actually quoted, and he actually mentioned that we need to actually come up, and he charged the Ministry of Health to come up with a solution to the rising runaway suicidality as well as mental health issues in the country. That's something he had done also last year in June, and that's why the task force was formed. So at the top policy level in this country and political level, I want to say that I know that mental health is a topic that is being looked at. So let me run through a few of this, a cross-section of the mental health impact that COVID-19 has had. The first one is the question of isolation. I think we've talked about it, and the speakers ahead of me who've spoken about isolation and the other non-pharmaceutical interventions that have been put in place. They're not really how human beings are created. I think that it's our brother Daniel who said that even in Italy, people are now hugging, and Dr. Kuria said in Kenya, we're shaking our hands again. It's because human beings are not wired to, in fact, I don't even know why they call it social distancing. It should have been physical distancing. We wanted it to be social closeness, but physical distancing, because it's a virus we're actually running away from, but we want to remain connected in one way or another. So human beings are not created for this. So this isolation is already bringing a lot of issues. And then also another effect is loss and grief. We're finding that people are not only losing their lives, especially in this part of the world, we've lost a lot of our livelihood, we've lost jobs, people have lost direction, and there's a lot of loss that is in the community right now. And if you imagine that right now, employers are doing anything in possible for them to actually kick people out of jobs. And that is actually one of the consequences of this pandemic that we can see, that people who are unscrupulous are taking advantage of vulnerable people who might not have any recourse, because a pandemic is seen to be an act of God, so to speak. Again, another impact we're seeing is the stress and anxiety. Many times, because this stress and anxiety is brought about by uncertainty, brought about by, we don't know what's going to come next. We don't know, even as we talk about flattening the curve. In this call, we have experts in the panel. But if you tell a common Kenyan on the street flattening the curve, they don't even know what you're talking about. So by the time you're telling somebody, no, we have to wait for the curve to flatten, you're really talking Greek to yourself. And the explanation has to be made in a way that people have to can understand this kind of public health communication, which is really the preview of experts. Also, another thing that we've seen happening as a result of this, as a mental health impact, is the rising cases of domestic and intimate partner violence, which I think at about 3 times more than what is reported in other times at this time of the year. It is really sad, because there's what I like to call the pressure cooker effect. People are staying in houses together the whole day, they're isolated, they seem to not have good coping mechanisms. And also because of another thing I'll talk about next, which is drinking, that is happening a lot, consumption of alcohol and drugs at home. You're finding that people are now not really being able to apply their impulse control, and they're really engaging in a lot of domestic disturbances. Also, someone had also mentioned the question question of depression and suicide. We're finding that the rates are also going higher, and mostly driven by the loss of jobs, driven by the uncertainty, and driven also by the lack of access of primary health care. So what you've seen, by people being told to stay at home, even the people who had other conditions stopped going to hospital. So we found that people were actually now dealing with their own conditions at home and not being able to get the proper care they required because of the stigma of imagining they would be infected if they went to the hospitals. Also, another thing that we are seeing happening is the trauma, as well as the post-traumatic stress that is coming from seeing how bodies are being handled and funerals are being conducted. All of these are very serious cultural and spiritual questions, because the rights to Africans, for example, if you speak about it to an African and then you make the African religious, now you've actually now compounded it. And then now you tell them that if somebody dies of COVID-19, they have to be buried within 48 hours. You're now, sure. And I cannot even imagine in countries like Italy, where in the beginning the rates were so high. Can you imagine without that connection with each other, without bidding your loved one farewell? And even Father Daniel talked about his colleague whom they could not even say goodbye to. So you can see that as it is, these questions that people are left with from a psychological angle. Also, we've talked about stigma. Of course, it's a consequence, and we've talked about the protocols also affecting our cultural and spiritual dispositions. Also, the other thing I want to talk about, the last two that I'll talk about in terms of the effects, is risk perception. For some reason, people until today think that the virus can only affect you if you came from Wuhan in China. And there's this perception to the common wananchi on the ground that they will never be affected because they don't get on airplanes and they don't come from China. And so because of that, you find a lackadaisical approach towards actually effecting some of the measures, the non-pharmaceutical interventions, which are pretty easy to do, the hand washing, the sanitizing, and all of that. And then finally, we have seen the phenomenon of underage pregnancies that have actually escalated, especially when you find that schools have been closed for a prolonged time. And now this is becoming a problem, especially in this part of the world. And the question we must be left to ponder about is what will happen to future generations when they have parents who are not ready to have them, and maybe they don't even have the social support to actually support them. So we really need to find a way to do that. So what can we do? I'll attempt to do this in less than a minute and a half that I have. First of all, government and policy makers have been doing a really good job. And I think that Dr. Kuri has outlined some of the things that have happened. One of the ones that I would like to mention is the economic stimulus package that His Excellency the President has actually put in place to cushion vulnerable communities. So that will actually help people in terms of worrying about where their livelihood will come from. That's very important. Also, I think that because of the Mental Health Task Force report, as well as other efforts at the Ministry of Health, mental health is now being accessed. And Dr. Kuri has talked about a lot of these efforts that are being done. And I think that is going to really help us in terms of taking care of the mental health of our people. Also, I think that we're now moving away from coercion in the beginning of the pandemic to persuasion when we ask people to apply their non-pharmaceutical interventions. So we're not using the stick approach, we're now using the carrot approach. We're talking to communities and saying, can we actually partner with communities as well as community leaders and religious leaders to talk to our people to say, look, we know that we want to congregate, we know we want to actually worship together, but can we also still continue to put on these measures because it's only for our good? Also, employers and institutions have to also come up with employee assistance programs, as well as become humane if they have to let go their workforce. Let me borrow 30 seconds. If they have to let them go in a humane kind of manner. Also, I think we also can talk about self-care strategies that people can actually put in place. There are many of them documented about how to take care of yourself, how to be aware of your mental health, and how to achieve balance, and especially remaining connected. And because we're here with people of faith, the connection is at two levels: connecting with each other horizontally with other human beings, but also connecting vertically with our spiritual sources, especially with God, for those who believe in God. And also, I think that seeking help within the family structure, with friends, and also with professional services will also really help us to actually curb the scourge that we're seeing right now of mental health, especially around this pandemic. I think that we don't have a choice now, but to actually get together and to do this together. And thank you so much for this opportunity. I think that as long as we all work together and we continue this conversation, we'll be able to we'll actually be able to take care of these mental health effects of COVID-19. Thank you so much.
Thank you very much, Dr. Gidua. May I now call on Sheikh Ibrahim Thome. Sheikh, please, in the layer.
Spoken, I'm a religious leader and a lawyer. So I'll go straight to the religious perspective. What does that happen? And I'll mostly share practical experiences that you've had. Unknown to many people, I am a member of the largest mosque in Kenya, which is Jamia Mosque, almost 90 years old. It is in the center of this town. It's considered as the center of Islamic activities in this country. I remember when COVID-19 became a reality, every other mosque was looking up at us. And let me begin by saying this, something that was mentioned by the doctor, or Dr. Oscar has just mentioned here about the role of religious leaders in all this. This is a medical problem. So somebody might ask this question, do religious leader or does religion have any role in this? I am one person who strongly believes that religion is not just about going to heaven. Religion is about living in this world. Professor Munene, there is no way you're going to heaven perpendicularly. You go to live in this world before you go to heaven. So how do we live in this world? And I keep on telling fellow scholars, sheikhs, one of the best prayers of Prophet Muhammad, may peace be upon him, was this: oh God, give us what is good in this world and give us what is good in the hereafter. Because I have to begin by living here well and then expect a good place in heaven. So religious leaders are supposed to help their followers, adherents of their religions, on how to live well in this world. So came Corona, and it became a reality that it's not there, it is here. You know, at first, Professor Monene, we were saying it is there, it is not here with us. Then it was here with us. So we quickly convened a meeting with the medics. There is an association of Muslim medics, we called them at Jamia, and their advice was, can you close the mosque immediately? And we could not come to terms with that. Jamia Mosque is 95 years old. Close the doors? No, not at all. Say, okay, so at least can you close the wet areas? Say, okay, we can do that. And I was given the responsibility of announcing that at the mosque. So that was at midday prayer. I now announced that now the mosque, we need to close some areas of the mosque. We were not very conscious about or sensitive to issues of social distancing. And now I hear the professor of psychology is coming with another one. Dr. Oscar is giving us something else, not social distancing, but observing some physical distance. So he didn't mention that. But come 4 o'clock, I had to go back to the mosque and give another announcement, which was very painful. That according to the medics, we need to close this mosque completely. Otherwise, many of our people will drop down dead. Again, I was told, Ibrahim, you're going to announce that. It was so painful, people wept because people did not want to accept the reality. And again, some of them were saying, is the coronavirus more powerful than God? I think we are worshiping a very powerful God, more powerful than the corona. So we should continue, we should even open the mosque more. But then we said, no, we have to close. And I remember after that announcement, and some people were crying, it was very emotional. And somebody confronted me at the entrance of the mosque, and he told me, what will you say on the day of judgment before God that you stood there to tell us not to worship God? And I had to say, no, I didn't say don't worship. You can worship at home. God is everywhere, so you can worship at home. And we had now to quote some religious text of practical incidences where the prophet, may peace be upon him, himself ordered that when there was a pandemic, people should even be quarantined. Those who are in should not get out, and those who are out should not get in. So we were a little bit at peace with people. Then we are talking about stigma. I'm going to share practical examples. On the day of Eid al-Adha, we lost one of the sheikhs. Again, because of stigma, I'm not going to mention the name. He died on the day of Eid. At around midday, I was coming from the mosque and I received a call from the relatives. And they said, you know what? It is believed our sheikh passed away because of this thing, COVID. We have not been able to prepare the body. We have been told not to touch the body. And people are even refusing to come and pay their condolences to us. So there was a problem. So I quickly called Professor Mohammed Karama, who happens to be the head of the National Muslim COVID response team, and asked him whether he's aware of what had happened. And he told me, yes, we are aware, and we are coming to handle the body. This sheikh was taken to the hospital, one of the big hospitals in Nairobi. They suspected he had the problem, so they advised that he should be taken.
Sheikh Ibrahim, are you still there? Sheikh Ibrahim, are you still there? Looks as if we have lost Sheikh Ibrahim for now. Hope he comes back. But we continue with the next level. There have been a few questions raised by the audience worldwide, and so we shall read a few of them and let the panelists respond to the questions that have come up from those listening to us, wherever they are. Question 1. What are the projected numbers and what plans are in place for dealing with these numbers? I think Dr. Kuria, that looks as if it is a question you can answer. Is Africa CDC reliable? Professor Issa, you're the one who talked about Africa, so maybe that's your question. And question 3, what is the mitigation for the discrimination faced by people experiencing the stigma? That one.
Can I complete, please?
Welcome back.
Yes, sorry for that. I just wanted to share with you now another issue of another complication brought about by stigma. I received a call from a lady from one of the estates in Nairobi because she knows I am a member of the National Muslim Response Team and also a member of Jamia Mosque. And she tells me, you know what? There is one of the houses that carries the dead bodies is here in a garage next to our estate. What is it doing here? What is this house doing here? Because there was a mechanic there, and they believe that this house is not supposed, after carrying a person who died of corona, is not supposed to be repaired anywhere near an estate. So I had to call again and find out. I was told, yes, one of our vehicles that is used to carry people who die of corona is being repaired, and the mechanics happens to have his garage next to an estate. And the people in that estate made such a noise that vehicle had to be taken away. So the issue of stigma is there. Now, from a religious perspective, should anybody be disgraced or looked down upon because of being afflicted by any disease? It could be HIV/AIDS. Now we are dealing with corona. The answer is no. And I get my inspiration of telling people that it is against religion to discriminate against anybody or to stigmatize anybody because of COVID-19 or any other disease. Allah subhanahu wa ta'ala, that is God, tells us in the Quran, and maybe Professor Munena, you can look at this, chapter 49, verse 11 of the Quran, clearly says, "O you who believe, let not a people ridicule another people." It is wrong to ridicule a person or to disgrace a person for something that they do not have control over. Today in a mosque as we pray, because now the mosques have been opened, we are observing the physical distance according to Dr. Oscar. We are observing that, but the cough, the normal cough, Professor Munene, is no longer a normal cough. And you can see people getting irritated just because of a normal cough. I live in Kajiado. We are very social people in the village. You stop to give your neighbor a lift. Many of them would turn down a lift, and especially when they look at my gray beard and they think I am within that age, 58 plus, 60 plus, who you anaonekana, maybe he's likely to be like me. So the stigma is there. But again, as even we talk against stigmatization, I think we should be cautious, because by telling people not to stigmatize others, it might be taken to mean, can you fully accept the others? And people might drop their guard. So I think we should exercise caution, even as we tell people it is wrong to stigmatize others, but at the same time, we need to accept that this thing is real, this is a reality, and we should not put down our guard. We just lost a chef last weekend in one of the places. I don't want to mention the place again because of the stigma, but we know he was afflicted by this. He's in a place where for a long time I would call relatives there and they would tell me, hapa hakuna corona, corona iko huku kwenu Nairobi, hakuna hapa. Then this old man who is about 70 years old, a very reputable scholar, he has some underlying conditions. He contracted the disease. We buried him on Friday. He was buried on last Friday. And now my fear is for all this time, and I spoke to him a few weeks before, and he told me, I am back in the village because here we are not exercising social distance. We believe corona is in Nairobi. It is not here. Now, as we're talking about numbers reducing in Nairobi, I'm afraid in those places where people did not want to accept this reality, it's going to rise up because people are still in denial. So let's talk about people not stigmatizing others, but at the same time, we should be cautious because this might be a call to tell people to drop down their guard. I think I'll stop there in the interest of time, Professor.
Thank you very much, Sheikh Ibrahim. And remember, you're going to pray the last prayers, the closing prayers. So don't let that machine again.
Okay, thank you, Prof.
Now, we had read a few questions. And one of these is, how can the family help their children on the depression that has been caused by COVID-19? I think Brother Daniel might be interested in that. And another question, is there any level of depression that can be tolerated? Oscar, that's your problem. How practical is physical distancing while our politicians are breaching the rules? Oscar, that's for you also. It's said it's you. Is government effort enough? Korea, that should be for you. Why are people leaving the affected people? Is it just stigma or is it fear? And I think that maybe Father Innocent looks as if he can answer that. Now, you each have 2 minutes to respond to any of the questions that has arisen. And I see Sheikh Omar wants to start.
You talked about the first questions. I forgot it when Sheikh was away. There were some questions related to what I was talking about. Can you please repeat it?
Okay. What is the mitigation for the discrimination faced by people experiencing COVID-19? I think that fitted you.
Yes.
Yeah. And the first question, I think, was directed Korea. What are the projected numbers and what plans are in place? Sheikh Omar.
Okay, I will talk about the mitigation, and you know, I was my presentation was focused on mitigation of stigma and the denials, and I have furnished various mitigations. First of all, what is very important in this situation is that one, people are in shock cognition. The mental perspectives are still not recovered yet. Therefore, what we require is that we change our attitude toward people in such situation. And since this has been there for a long time, I mean, diseases like this ones were occurring, and we had read from the scriptures, we need to change our attitude from the, I said we need a paradigm shift in the situation. Not only this one, from and to our normative cognition. Our mental perspectives should be changing that the deaths are there to happen, whatsoever the cause might be, and we should be ready to face and be normal in our situations.
Dr. Kuria. Or maybe we go to Brother Daniel. Brother Daniel?
Well, I think you asked me what the question about those about children or what else, what the projections are. Because about children, I'm no pediatrician. What I can say is that we have been battling in the country the issue of school reopening because children are social animals. They need to be together. We all need to be together. So we have to find a way to go back to, it will not be normalcy. Not the normalcy we were used before. There will be a new kind of normalcy that we shall have to invent by learning how to cope with the risk management. I mean, congregating when you come together in a situation of epidemic is risky. And as we cannot separate from each other totally, we have to learn to manage risk. And I think this skill, it has to be learned, because if I follow
Thank you. Dr. Kuria, the numbers and the government effort.
Thank you, Prof. again, and the rest of the panelists, and thanks for that question. I know it's a question that keeps coming even in our press briefings. What is our projection? And people I know were taken to a projection that was given sometimes at the beginning in our response, that Kenyans expected 10,000 cases per day, per month towards April, and that they say that figure has never been reached. Now, the projections, to tell our viewers, is that are done by a consortium of epidemiologists and statisticians from about 4 reputable organizations. And the projections they gave at the beginning, of course, were based on the worst case scenarios. And over time, of course, with the placement of restrictions and all the containment measures, the projections that have been there, of course, have changed. And what Kenyans are now able to see as figures, they are wondering whether the projections were right. And as I said in the beginning, the numbers, the projections are all based on the number of positive cases that we get every day, measured against the number of tests that we are doing and against the positivity, measured against the containment measures they are doing, and also measured against some mobility that we are experiencing. So when all these things are compounded, because you need to see how people are moving around the country, then projections are changed and altered towards as the pandemic progresses. All we can say here, because of the limited testing today, we cannot base the figures that we are having here as the figures for the projections. What we have is knowing who we are testing and where we are testing, and based on who we are testing, then look at our positivity rates. And we may say that since the beginning of the pandemic, our rate has moved from about 2% at the beginning up to a high of about 12% towards the end of July. And since July, that positivity has been going down, and currently we are at about 8%, showing some level of decline. However, it will be desirable here to achieve the whole prescribed positivity of about 5% before we could open up all economic spheres, including schools and all places of worship and entertainment centers. So as at now, we are averaging at around 8%, between 5 and 8%, and we hope to achieve our 5% before the end of October. So all projections that have been provided by the consortium are pointing towards a decline of this percentage to as low as 3% by the end of October. Of importance, of course, here is that 47 of our COVID deaths in Kenya are still between 20 and 57 years of age, which is of great concern because it's the most productive age group in our society. So we are still monitoring our data and using all the parameters that I have mentioned here to see where we are, but the most important is that our positivity rates are declining as of beginning from mid-July. Thank you.
Thank you very much, Dr. Kuria. Oscar, you had a few questions. Take 2 minutes.
Yes, thank you, Prof. The first one that the viewer asked was, is there a level of depression that is acceptable? So first of all, what I would like to say about depression is that I think that when we are lay people, sometimes we use the word depression loosely, and it might not mean exactly what clinically depression is. So let me differentiate. I think that there is what I would like to call situational depression, the feeling you feel when your team has lost over the weekend. Maybe they were playing soccer and you lost and you had really thought they were going to win. You can feel low. Or maybe if you actually don't do well in an exam, you'll also feel a bit low. You can say that I'm depressed, but in reality, you're not what I would call clinically depressed, but you might be feeling feelings of lowlessness, being low. When you start talking about clinical levels of depression, which might maybe what the viewer is asking is, what is a threshold, or how can I tell if I need help? What I would like to say is that if the depression that someone is feeling, which most likely will be chemically caused, is one that actually makes you not able to get out of bed in the morning, not feel like you're motivated to do the things you like to do, and especially lasting over a period of more than 2 weeks. If you feel like you're in that situation, most likely you need to go and get some help, and especially you need to get some professional help because there could be something happening. Now, to also say that depression could also be as a signal for other things, we call depression the great imposter, which means that it could also be another thing that it's signaling in your body, even not itself as a major depression disorder. So you will need to go see an expert in that case to be able to actually distinguish what is going on. Now, the next question, if I can answer in a short way, is the one that was asked: how practical is physical distancing if politicians are not doing the same and they're holding rallies? Now, of course, that is a very good observation by the person who's raised this question. But it is practical for us. You see, sometimes I say that, yes, you can look at a politician and imagine that people have gone to the rally without masks and all of that, and then you decide you'll do the same thing. What I'll say is this: coronavirus does not know your political party. It also does not care who you're voting for now or in the future. You might not even be alive to vote for that matter if it actually gets you. From what we've heard from Brother Dr. Daniel is that his colleague got it and showed symptoms at least, and within 12 days he was normal. So I think the very thing I would actually ask people to do is this. Of course, it's very responsible of politicians to do this, and especially because they have big followings of people, so they're not really leading by example. But what I'll say, I'll ask Kenyans to do is this: value yourself, value your family, and don't let politicians tell you how you're going to operate, especially with your families. That is the most unwise thing you can actually do. So is it practical? Of course, it's not practical if you really believe in the politicians, but I would actually say it's the best thing to do for yourself. Thank you.
Professor Isa?
I'm very sorry, but I think I forgot the question. Can you repeat it again, please?
The question was, I think, did I direct the one on the family to you?
The one of the CDC, the Center for...
the CDC, yeah, the CDC. The African CDC, is that reliable?
Well,
is African CDC reliable?
Well, unless we are condoning our own, it's as reliable as you can. It depends on the data. It's a garbage in, garbage out. If you collect the data and the data collected data is reliable, then we can say whether we can it's as good as any other things. Do we have any better measures? This is what we have. And as Dr. Oscar talked about, I think it was Dr. Kuria, I'm a forecaster myself, so you can only forecast. Someone asked whether somebody could forecast what the COVID-19 numbers will be like. So your data can be as good as the one you collect, so you can project it from historical data to see what the data might look like maybe in the next month or 2 months. That's one, I just wanted to mention that comment, but specifically whether we should trust the Africa's Center for Disease Control, do we trust all the data we have, Africa Way Data? This is the best we have, and data is never accurate, so, but it gives you an estimate, it's just a roadmap. So instead of just completely rejecting it and saying it's not useful, maybe you can just torture the data, twist it, and see if there is any useful information. And we know, of course, there are many things that has to be considered when you're looking at the data, especially the health data, and especially looking at Africa as a whole. It's a huge thing to consider. And I think they're trying the best they can, and you don't expect them to be perfect. At least it can be used to get some estimate or some information.
Father Innocent. Unmute yourself.
Is there any difference between stigma and fear? Was that the question? Yeah. Stigma is the result of fear and denial. It's because we fear the sickness, or in this case, COVID-19, that we don't want to associate with anybody who has been diagnosed or is sick with COVID. So we want to keep people want to keep distance. But it's also a result of not wanting to see the reality in face. It's a kind of also of denial. So because of fear, we ostracize, we isolate the person. And actually, myself, I've just experienced the same. I mean, and I could feel I've just lost a friend, and I went for the celebration of the Mass. And then immediately some people called my community. I said, we saw him celebrating Mass somewhere for somebody who has died of COVID-19. So all this is because of fear, and then denial because we don't want to see the reality in faith. But here we are talking as people of believers, people of faith, and our religious tradition asks us to care for those who are in sorrow, to comfort those who are mourning. And as Sheikh Letomi said, no one should be discriminated whatsoever because of sickness or because of any other reason. So the invitation is to pull from our religious traditions and spiritualities to support those who are suffering from any kind of disease. And in this time, it's COVID-19. I think it's the role of us as religious leaders, not only religious leaders, but is the duty of every believer to remind ourselves that our holy scriptures ask us to be near those who are in need, and especially in this case, those who are suffering from COVID-19. And at the same time, as Sheikh Letomi said, welcoming and going towards those who are suffering, or those who are the victims, we have also to be aware that it is a reality, and we should continue to keep the measures, at least the physical distance that is required by the World Health Organization.
Yeah, thank you very much, Innocent. We are running out of time, although I can see some more questions coming up as to whether there are any good strategies to deal with matters of livelihood and the loss of jobs, but there's no time to ask people to comment on that. At this time, I would like to thank everyone, the organizers, Harmony Institute and Gaza University and Uma University for collaborating and putting this show together. Then all the panelists who have been gracious with their knowledge and willingness to share and give good advice on what people should do. And one lesson that comes through is that we should not let down our guard. We should keep clean, wash our hands, wear the masks, wash the bodies, and don't over-relax. Otherwise, it might come back with a bang, the way we do not want. So I would like to thank every one of you and participate with us in the next time we have something. Harmony Institute is there to help facilitate this kind of discussion and issues. We thank the government of Kenya through Dr. Kuria. You are the government person here, so we thank the government through you. We thank Italy because Brother Daniel is all the way from Italy and he's here. So we also thank the Somali people because of Professor Hodan Isse, and say hi to your neighbors down there. And we love them, we love everybody. We should all interact. And Oscar is my colleague at USMU. So when he's not counseling people in psychology. And Sheikh Omar, thank you very much. And the innocent. And for some reason, Sheikh Ibrahim has disappeared from the screen, and we need him to pray, give us the closing prayers. Ibrahim, Sheikh Ibrahim, are you around? And remember, we asked him not to disappear. The machines are not cooperating very well in that regard. If he is unable to be with us, and Sheikh Omar, are you still there? Oh yes, you are there. Please do the honors of closing the whole thing on behalf of Sheikh Ibrahim. Please.
Okay, let us pray with Roho Mkunjofu according to the way we say here in Kenya, dedicated to Allah subhanahu wa ta'ala. O God of all creation, we are very thankful to you for assembling us and allowing us to come together while healthy and imparting all what we have in our knowledge. Oh God, keep us safe all over and our families and everybody that we cherish and all the mankind, and save us from the calamities that we are facing today. Oh God, help us and our families to be safe all over. Oh God of all creation, we praise you always. We love you. We are religious leaders and we are attached to you. We raise our hands and our hearts to you so that we salvage the mankind from the decadence and the calamities that we are in. We are today very humbly before you. We don't know what to do, and only with your powers you can save us. In your name alone we pray. Amen.
Amen. And with that, we come to the end of this interaction. Thank you very much, Mustafa, and thank everybody else. And please, the next time we have a session like this one, please show. I see Ibrahim has come back. Sheikh Ibrahim, are you there? Just his name has come back. So, but we have come to the end of this exercise. I thank every one of you. Please go safely and remain safe wherever you are. We need you. The world needs you. Your countries need you. Amen.
compensated. November last year for another 9
You are
years.
eating. You are eating.
To stay for another 9
Oh,
years.
Ibrahim.
But
Say something.
it has to pass here.
Your brother Sheikh Omar said the prayers on your behalf,
We can leave.
but you'll be allowed to say one thing.
Businessmen
Oh,
admit
thank you.
BBC
I got lost.
from Kenya Railways, but they are
Thank you.
now
Yeah.
I did represent you.